pretty pathetic when you get semi-retired, you know, you think the only important thing in your life is cleaning up your shop and shoveling snow. You forget to look at your basketball games. You forget to look at your calendar. Okay, so I'm going to talk to you guys today about, actually this is kind of not inclusive enough. End-tidal CO2 is a little bit limited. I'm going to talk to you about waveform capnography and end-tidal CO2 because waveform capnography is a real significant tool that actually tells you a whole lot more than just end-tidal CO2. But before I do that, I just want to appeal to your paramedic pride, not like pride the mortal sin, but like pride. It's important for you to realize that you play an important role in the system. And this whole topic of end-tidal CO2 and waveform capnography is an example of where pre-hospital medicine paramedics have really kind of informed the medical community. So I was an ER doc at a major trauma center and cardiac center for 30 some years and never used end-tidal CO2 in the emergency department. And I never even knew a thing about end-tidal CO2 until it became an important tool for paramedics. So there's an example of where, you know, the pre-hospital medicine people have sort of been the tail wagging the dog, if you will, because now emergency departments are starting to use end-tidal CO2 because they see what a great tool it is and how well it's worked for you guys. So it's a lot like you have to recognize the fact that the cardiac system that exists in Spokane today, the stroke system, the trauma systems, they all exist in part because of the pre-hospital contribution, particularly like the cardiology component, the acute coronary syndromes. I'm going to diverge a little bit here, but it's okay, because it's important for you to realize how important your role is. When I first came to Spokane, if somebody came to the ER with a heart attack, you check them out, you do the 12 lead EKG, and you got done seeing the 5 other patients that were ahead of that patient. You looked at the 12 lead EKG and you said, oh crap, this guy's got a heart attack and he's been sitting here for 30 minutes. So then you call the doctor's primary or the patient's primary care doc, and he said, well, I'd like to use this cardiologist. And of course, you have to get the cardiologist off the golf course. And pretty soon you're 3 hours into this thing, and the guy's been sitting there with a heart attack the whole time and infarcting more and more tissue. So what happened was when I first started working for the Spokane Fire Department back in 1997, I immediately taught the 12 lead or the paramedics how to read 12 lead EKGs. And this was before we had computers that read the 12 leads for us. You know, now they have software that actually is geared toward paramedic interpretation of 12 lead EKGs. So in a lot of ways, you don't have to know as much as you did back then. But anyway, when the medics got to the point where they could start making the diagnosis of an acute MI in the field, then they started thinking, well, gosh, this person's having a heart attack. I'm going to take him to the place that, in my perception, is the best ER for taking care of people with acute coronary syndrome. So what did that do? That created competition among the hospitals. So now the hospitals are thinking, well, this guy's going to take their patient to wherever they think they're going to get the best care. So everybody sort of went to school on improving their metrics with regard to acute coronary syndromes. So pretty soon they had call schedules in place where you could call the cardiologist right away. Cath lab came in right away. And it went from like 3 hours to door-to-balloon time, sometimes 5 hours door-to-balloon time, to now in Spokane, like 60 minutes door-to-balloon time is average. And that's actually better than the national goal by quite a bit. It used to be 90. The goal is 90 minutes, but in Spokane we consistently do 60 minutes. All because of the fact that the pre-hospital people created this sort of competition among the hospitals. So this is just, and there have been some, I have to say, this is one of the technological things that the paramedics have sort of introduced to the emergency departments. There have been other things that they introduced that, like the McSwain dart, which you probably don't even know about, mass trousers, those kinds of things were things that were introduced by the pre-hospital sector and then turned out really to have not ever been really tested for efficacy, and so eventually they sort of fell away. But this is not going to be one of those things. This is a real contribution. Okay, enough of that. So we'll jump in. So the end-tidal CO2 monitoring can be done both invasively and non-invasively, meaning you can do it with people who are non-intubated and you can do it with people who are intubated. And I think it's really helpful in people that are not intubated. Everybody uses it for people who are intubated, but I think it's actually most useful for people that are not intubated. And these are, you know, pictures of the intubated variety and the non-intubated variety. Sure. Okay, so what used to be the holy grail here was we used it for confirmation of tube placement, right? So and it was just an end-tidal CO2, and initially people were using colorimetric changes and that sort of stuff, and some people still do that, but that's kind of antiquated, little bit like my flip phone, you know, which is part of the reason I'm late today, because I don't have one of those newfangled things that reminds you of your life every day. But at least I assume those smartphones do that, right? Don't they alarm you and say, hey, you're supposed to give a lecture at 9 o'clock and it's 10? Anyway, so that was what it was for initially. So it was real-time objective component, immediate recognition of tube placement. So if you didn't have a way end-tidal CO2 reading, then you knew you weren't in the right place and you had to pull the tube out and replace it, right? Everybody knows that. But it's also important because of the dynamic nature of patient care. So we're going to go beyond the Holy Grail today and talk about some of the other neat things you can do with this. So here's some of these bonus secondary uses that I'm going to focus on today. You could objectify the clinical course of asthma or COPD. This is really important. And in my experience, one of the hardest things in medicine is trying to figure out when you need to intubate somebody who's crashing with asthma or COPD. And I really don't like to paralyze people and intubate them. I like to intubate them when they're needing to be intubated. So, because once you paralyze somebody, if you don't get them intubated, you're sort of screwed, right? I mean, you can ventilate them and all that kind of stuff, but you really, you know, the main rule of medicine is do no harm, right? So when you paralyze somebody to intubate them, you potentially can do great harm. You know, if you get them intubated, you're a hero, but if you don't, you're a goat. So I always found it difficult to decide when to intubate and when not to intubate. And I didn't want to do it too early if I didn't have to. So one of the nice things you can do is I'll show you a way that you can determine whether or not somebody needs to be intubated, or you can predict whether they need to be intubated. Because a lot of times, you know, I'm sure even as EMTs, you've noticed that asthmatics a lot of times can have a lot of kind of supratentorial overlay. So, you know, they're struggling to breathe, but the truth of the matter is they're not really as bad as they look because they're dramatic. And then you have other patients who are not at all dramatic, and you think they look better than they really do, and they end up crashing on them. Every once in a while, a young asthmatic patient dies because a pre-hospital provider was not able to recognize the fact that they needed to be intubated. They thought that they were being dramatic, is usually what happens. You can identify loss of spontaneous circulation. So if you've got somebody who goes into cardiopulmonary arrest, you're going to be able to see that right away with the CAP waveform. You could gauge effectiveness of CPR. I don't know if you knew that or not, that you can tell from the waveform whether or not you've got good CPR, and also from the end-tidal CO2 level. You can establish the futility of CPR, so you can actually predict whether or not somebody's going to actually respond to resuscitation by their end-tidal CO2 initially. And then you can also target the respiratory rate in people who have high intracranial pressures. So, you know, back when I was a kid in medicine, which I'm certainly not anymore, I don't dye my hair either, by the way. You know, they just told us to hyperventilate people with it.
injuries. So we would hyperventilate them so much that we would completely shut off their cerebral circulation. And now they say, don't do that. They say you should ventilate a little bit too much, but not too much. So you have to be real careful, but how do you do that? And this is a nice way to gauge how much ventilation you need to do. So we'll go over all that stuff, and maybe I'll even present you some cases. So what's end-tidal CO2? First of all, just we'll run through the physiology here. So you breathe in, and your lungs oxygenate your blood. The blood gets circulated by your heart to your brain and to your tissues. I put the liver in there because I think the liver's an underrated organ. It's actually the chemistry shop of your body. It's a remarkable organ. But it's all the organs. And then the byproduct of metabolism turns out to be CO2, and we'll talk about how that happens. And then you blow it out in your lungs. So when you blow out CO2 from your lungs, you're actually demonstrating that all of these things are working, right? I mean, if you're not metabolizing, you're not going to blow off CO2. If you're not breathing, you're not going to blow off CO2. And if you're not circulating, you're not going to blow off CO2. So it's a really great tool for measuring all kinds of things. So the end-tidal CO2 is actually the end of expiration. Sometimes people look at this and they think this is the inspiratory waveform. Actually, this is inspiration right here. This is the expiratory phase. All right. So end-tidal CO2, when you just get the recording of the end-tidal CO2, if you look on your monitors, you can have a waveform, or you can have this trending, which is the end-tidal CO2. That's what it's going to record for you, the trend. Okay. If you guys have any questions, just ask them. Okay, don't wait till the end. So, in this particular case, non-invasive measurement of CO2, and actually can be invasive or non-invasive. I don't know why I said non-invasive. The normal values are 33 to 42. So here's kind of that same thing that I just demonstrated for you. So you breathe in, the oxygen goes to the muscles and organs, produces energy, but the byproduct of that is carbonic acid. And carbonic acid, if you know chemistry, you can see there's just basically water and CO2 there, right? So the water gets removed, and it's CO2, it gets blown off in the lungs, okay? And so O2 sat is helpful in terms of just measuring the oxygenation, and that's about it, really. It doesn't do much more for you. So it's a very limited tool compared to end-tidal CO2 or to waveform capnography. But what you can get with the waveform capnography and end-tidal CO2 is oxygenation, perfusion, metabolism. Can you think of a time when you might have no metabolism? All these other things are working, but metabolism alone is responsible for you not being able to produce CO2. What? No. Where you just shut down metabolism. Everything else is working, at least initially, and then metabolism is just shut down. I'll give you a clue. Overdose. Of what? Heroin? No. No. Well, I mean, you could have a problem with that too, but it's not because it shuts down metabolism, because it shuts down respiration. But no. What'd you say? No. It's something that firefighters should think about.
Cyanide.
Yes. Cyanide. And CO also. But cyanide in particular will actually shut down metabolism completely. So everything else could be working, but you're not able to metabolize anything because it junks the whole metabolic pathway, let me just say, so that you can't produce energy. You don't get any byproduct of CO2. But that's about the only time when that's really a relevant consideration. But for those of you who are firefighters, it's something you should always keep in mind when you're fire, you know, somebody comes out of a fire with a cardiac arrest or whatever.
So, metabolism and then ventilation. So perfusion, metabolism, ventilation, and what's the other one that I didn't put in there yet? You gotta have circulation for any of that to work. So two main functions that are required are circulation and ventilation. Metabolism in that rare circumstance that I just mentioned. But for the most part, we're talking about circulation and ventilation, okay? So if you lose your waveform, either they're not circulating blood anymore or they're not breathing, okay? So ventilation is, as you know, tidal volume times respiration. And I don't think I need to go through that with you. This is pretty patently obvious, right? You guys know this. Okay, so here's kind of an important slide, and now I have to look at it because I didn't get a chance to look at this stuff last night since I hadn't consulted my calendar. So it can be a little bit confusing, but here's what's really important for you to just memorize. This is the baseline gospel, okay, and then everything else kind of builds on this. If you don't accept this portion on faith, then you're not going to be able to apply the science and reason your way through some of the other ways we use this. So hyperventilation always results in a drop in the CO2 level, the end tidal CO2 level, okay? Does that make sense? And then hypoventilation always results in an increase in the CO2 level, okay? So if you can just buy that, then we'll be okay. You kind of wonder, well, if people hyperventilate, aren't they blowing off more CO2, right? But they're not, because what you're measuring is the end tidal CO2, right? So it's kind of, sometimes if you try to reason your way through this, it gets a little bit tedious, but just accept it. Hyperventilation drops your end tidal CO2, hypoventilation, okay? So you can get hyperventilation with anxiety, bronchospasm, pulmonary embolism, pulmonary edema, I mean, you know, all kinds of things. Get hypoventilation with any kind of sedation, all kinds of intoxications, overdoses, post-ictal states, head trauma, stroke, all that stuff. And then the part where it sort of gets a little bit complicated is these people who can start off hyperventilating with a low end tidal CO2, like asthmatics and people with pulmonary edema and people with COPD exacerbations, when they get tired, before they need to be intubated, they're going to start dropping their end tidal CO2, or they're going to start dropping their ventilation, and then their end tidal CO2 is going to go up. So as they fatigue, they might go from having a low end tidal CO2 into the normal range, and you'll think, oh yeah, they're getting better, but they're actually not getting better. They're getting worse because they're getting fatigued, and then the next thing you know, they're going to be retaining CO2. Their end tidal CO2s are going to go up, and that's just before they crash. So you need to sort of intubate them in that little window of time there. Does that make sense to you? Okay. Some other reasons for low CO2 is decreased cardiac output. You could get it in all kinds of hypotension. So if you're under perfusing, if you got somebody who has like a bad trauma case where their blood pressure is 40 or something like that, you're going to be under perfusing, so they're going to have a low CO2. And then we talked about decreased metabolism. Also, hypothermia could do that. Could decrease the metabolism for reasons that I'm sure are clear. So it would be something to think about when you have cold water drowning, maybe too. And then other reasons for high CO2 would be fever, sepsis, anything that causes increased metabolism. Certain drug overdoses like methamphetamine, etc., can cause people to get hypermetabolic. And then there are just certain people that are chronic hypercapnia who have elevated CO2 levels. Any questions so far? Okay. So basically that end tidal CO2 is, it essentially mimics the O2 saturation in the blood. or not the O2 saturation, the CO2 saturation. Okay, so that's just redundant. So normal capnography values 35 to 45, okay? It can be affected somewhat by imperfect positioning, and I've read that you can be off by as much as 10% in your initial baseline value, but the trending is more important than the actual absolute values. And that's part of the reason why they give you a range of 35 to 45 for normal. So end-tidal CO2 monitoring, if you have elevated and continually rising, might have increased CO2 production from any of these things. What might you see if you have somebody who has an elevated CO2? Just, I want to see if you're reasoning through this properly, okay? So you have somebody who has increased CO2 production from a seizure. What would you expect to happen over time? What? Right? Okay, so right, so that's half of the equation. What's the other half?
What is overworked?
Yeah, so they're hypermetabolic from all that muscle contraction and everything that happened. They usually decrease their breathing during the seizure, so they're going to get an elevated end-tidal CO2 from that, okay? And as they recover from the seizure, what are you going to see happen? Their end-tidal CO2 is going to go up initially because of the fact that they're blowing off all that lactic acid from the seizure, okay? Because that is going to, the acid is going to be metabolized and ultimately removed from the body in the form of CO2. That's how your body quickly gets rid of acid. It's by hyperventilation. So then what are you going to see? Right. So with a seizure patient, you might see that trending elevation, and then it'll go down once they catch up. Okay. I just want to be sure you're thinking about this right. It sounds like you are. Is that straightforward to everybody here? We're not. Okay. Because if you're not following, just say so, and we'll go back and go over it. Okay, so the rest of this is kind of redundant. And then, of course, whenever you see something change, you want to check your equipment and be sure you don't have an equipment malfunction, because not everything is perfect. You know that. The machines, we can be overly dependent on machines. You got to be real careful to be sure that what they're showing you is consistent with what you think they should be showing you. On the other hand, you don't want to ignore stuff that doesn't seem right and just blame it on the machine. I remember one case that was particularly disconcerting for me back when I was reviewing cases as part of my job in the Spokane Fire Department. There was a woman who was hyperventilating, a pregnant lady who was hyperventilating, and the paramedic just assumed that she was neurotic or anxious or whatever, and her O2 sat was like, I think 75% or something like that. And so, in spite of the fact that the O2 sat was like 75%, it should have made the person think, hey, there's something not right here. They just assumed she was hyperventilating and anxious and had her breathe into a bag. And this was early in my career. We immediately made it so nobody could do that anymore. But the lady died, and her fetus died too, of course. And it was because she had a pulmonary embolism. And they just ignored what the machine was telling them. So it goes both ways. You got, the machine sometimes can be right, and you're not thinking clearly. Or, you know, the machine could be wrong, and you've got to figure out which the case is, okay? So we talked about all this. I don't know why I've got this in there so many times. I guess I'm trying to make a point. Yeah, so you want to pay more attention to the trend than the actual number. It's a sad commentary on modern life. So here's some waveform pearls for you. You need to watch both the morphology of the waveform and the absolute value, and the morphology's cool. So we'll get into that a little bit. The waveform will change before the value will. Okay. And then the trend is more important than the initial value. So here's a normal waveform. A to B is the baseline, which is inspiration. Okay. B to C, where's that? Is the rapid, sharp rise of exhalation. So that's the early phase of expiration. And that should be almost a straight up line, as long as there's no obstruction to breathing. So if you had somebody who had like bad asthma with bronchoconstriction, or somebody who had terrible pulmonary edema with a lot of airway edema that's causing the airways to be narrowed, what would you expect? Or maybe somebody who has bad like end-stage COPD with emphysema and no elastic recoil in their airways, so there's a lot of resistance. What would you expect the waveform to look like? What would you expect that upward rise to look like?
More gradual.
Yeah, so it would be more sharp bend, right, than it would be this nice square looking. So then the alveolar plateau is kind of when the air is just you're running out of air in your lungs, and it just kind of levels off. And then you take a deep breath, and that's DE, when the air rapidly goes into your lungs. And usually when you have obstructive pulmonary problems, this is not going to be affected nearly as much as this. Why is that? What is it about pulmonary physiology that makes it so that expiration is a lot easier than inspiration? I'm sorry, inspiration is a lot easier than expiration. Sorry. Okay,
Push
so
it out. Out is more of just like the pressure for the muscles has been relieved, so it's just kind of going back out to.
yeah, so when you take a breath, you do it by creating negative pressure in your thorax, right? And that causes your airways to expand because there's negative pressure. So they want to naturally expand. When you're blowing air out, you do that by creating positive pressure in your thorax, and that naturally causes your airways to collapse. So that's why when you have obstructive pulmonary symptoms, it's usually stridor more than wheezing. Now, wheezing is also obstructive, but normally wheezing gives you an indication. Wait, I'm sorry. It's usually wheezing, not stridor. I got it backward. So wheezing is an expiratory airway sound. Okay, so you can get wheezing with COPD exacerbations, you can get wheezing with asthma, and you can get wheezing with CHF. Some people call that cardiac asthma. But really what it is just edematous airways that are narrowed, and so you have this kind of wheezing. Did I just confuse everybody completely? Hopefully not. And then stridor is an inspiratory airway sound. And why do you get stridor? Is it because of intrathoracic obstruction? Yeah, it's extrathoracic obstruction. So the opposite of what I just said applies there. When you take a deep breath, your extrathoracic airways collapse because you're sucking air into your thorax. And when you blow the air out, your extrathoracic airways expand. So it's the opposite. Okay, now that I've thoroughly screwed you up there, we can make some progress. So these are some capnography waveforms that you'll see. Normal is that top one, so you can see 45 is the value that you're looking for, and the waveform is a nice square kind of looking waveform, right? There's a little bit of a slope to the expiratory effort, but that's normal. Then with hyperventilation, you're going to see that your waveform looks kind of like the normal waveform. It's just that it happens more frequently, and because you're hyperventilating, your end-tidal CO2 is going to go down. Remember, I told you that's one of the two foundational things you have to accept on faith. And then a lot of times your baseline will be above.
the normal baseline because of the fact that you're not completely emptying your lungs.
And then hypoventilation, predictably, would be exactly the way it looks there. So you have a longer waveform, you have a higher end tidal CO2, and generally you can't go below the baseline. And then the last one, the bronchospasm, and this is what you can see in asthma or a COPD exacerbation or CHF, any of those obstructive phenomena. Any questions on this stuff? Okay. So this is the equipment. One of them is for intubated patients and the other is for non-intubated patients. These are the ones for non-intubated patients, and there's an adult version and a pediatric version, and I don't understand the physics enough to tell you why they have to be different like that. But
So back on your last slide with capnography form out the bronchospasm one, if you have somebody with a suspected allergic reaction, you throw them on end tidal, you're going to see something kind of like that as their airways constrict.
you might.
Okay, and that can kind of indicative of the progress of what kind of reaction they're having.
Yeah, you know, the truth is with the with somebody who has bad bronchospasm
and laryngeal spasm, which you frequently get with anaphylaxis, I've never really thought about this before. It's a good question to ask.
you might see more of a peaked kind of a waveform because of the fact that you're going to have inspiratory and expiratory obstruction because you got laryngeal spasm as well as bronchospasm. So that's a good question. I think you're more likely to see the sharp end kind of waveform. That's a particularly relevant question because really my experience has been that a lot of the people who think they have anaphylaxis really just are crazy. I shouldn't say they're crazy, but they're anxious. And, you know, they got bit by a bee and they're sure they're going to die. And they're hyperventilating because they're freaking out about the fact that they got bit. But generally, the rule is if they don't have a rash or at least itchy skin, then they don't have anaphylaxis. So it's almost like a rash is the sine qua non, that's Latin, that means without which you do not have of anaphylaxis. The problem is that sometimes it can be just a little bit delayed in onset. So as a paramedic, you have a limited period of time with the patient. So you want to be a little bit careful about just writing them off as a nutcase. The other thing is there is this subset, a small group of patients who actually get gastrointestinal anaphylactic symptoms. And those are the ones that'll burn you. It's a very small percentage, but they can. So I used to say absolutely if you don't have a rash, you don't have anaphylaxis, but now I don't say that anymore because there have been these cases of gastrointestinal anaphylaxis. So people have a lot of gut complaints, and the reason they do is because they've essentially got a rash on the line of their gut. And you don't see it on their skin. Yeah.
What's your opinion on mass T cell activation? Like, because I've heard like some people think it's all psychosomatic, other people think it's an actual real thing. And we had a patient who supposedly had that a while back.
I'm not sure what the heck you're talking about.
Back in the room, Greg. So like, where apparently your guys are hypersensitive to,
Yeah.
are supposedly allergic to almost everything.
Yeah. You know, I can't comment on that because I'm not up on that stuff. But I can tell you there are these two, we're kind of getting a little bit off track, but there are two major categories of exceptions to the whole anaphylaxis discussion. And these are patients who, well, you tell me what they are. These are people who won't respond to all the usual things that you use for anaphylaxis, but they appear as though they have anaphylaxis, or at least an allergic reaction. Two major categories that are not going to respond to anything that you've been trained to do with regard to anaphylaxis. No.
we talked about hypochondriacs a little bit. I mean, the people that are just anxious and think they're really sick. Who said something else? No. So people who are taking ACE inhibitors, a lot of times their tongue will swell all up and they'll look like they're having an anaphylactic reaction. And that is one of the most common side effects of ACE inhibitors. You know, all the prills, like Cinepril, all the antihypertensive drugs that are ACE inhibitors. And then the other thing is a thing called C1 esterase deficiency or hereditary angioedema. Usually those people die before they're 30 years old from laryngeal spasm, cardiopulmonary arrest. But they will not respond either to the medications that you're used to giving, and you might just have to intubate and ventilate them. So if somebody says to you, I have hereditary angioedema, then you better be ready to intubate and ventilate and forget about all those other things that you do. And if they have it, they'll tell you they have it because they know they have it. They will have had lots of episodes in the past, unless they're just a kid. But that was a good question. Appreciate you thinking outside the box. That question is way outside the box. I think I know what you're talking about, and I don't know. You know, some of the stuff that we used to think was voodoo is really starting to be real. So it's conceivable. But there are these people who are just allergic to everything, and I think that's who you're talking about, maybe. But I don't know that much about that stuff. Did I go backward? You're going to be proud of it. So basically, like I said before, ask yourself, does this confirm what I'm thinking, or am I surprised in any way? So let's see. How long have we been at this? You guys get to the point where you need a break, or should we go a little further? Okay. So here's a situation where it would be very helpful for you. You guys give a lot of pain medication in the field. You don't do a whole lot of procedural sedation, but you do some. I mean, if you're going to cardiovert somebody or something like that, then you would want to be able to monitor them, right? And the way people have done it in the past is with O2 sats, right? But waveform capnography, just end-tidal CO2 is a way better way to do it. So here's a nice comparison here. So which of these things do you think predicts the change first? It's pretty obvious from looking at the form there, but the O2 saturation, which is what we used to look at, or what we normally used to look at, is, well, I'm going backward. Okay. Obviously, the waveform capnography shows the change almost immediately. So if somebody starts to slow down their breathing or stop breathing, the end-tidal CO2 is going to manifest that way before anything that has to do with oxygen. If you happen to have an arterial line in them, it'll show up a little bit later. And if you don't have an arterial line in them, you're just doing pulse oximetry, it's going to be way out there. So waveform capnography is a way better way to monitor these patients that you give pain meds to. And frankly, every once in a while, we see someone who gets offed by a pre-hospital provider who gave them some pain medication for a legitimate reason, but maybe too much because the patient is elderly or something like that. Usually not a drug problem so much as a dosage problem. And the ones that will get you are little old ladies who fell and maybe broke a hip, and you give them the usual dose of fentanyl, and the next thing you know, they stop breathing. So you have to really cut the dose way down and titrate up rather than try to go backward. It's always better to give more than give too much to start with. But this is a nice way to monitor whether or not you're safe. So another nice thing you can do is identify CO2 retainers, which is always difficult because when people lose their respiratory drive, their CO2 saturation will go, let's see, when you lose a respiratory drive, they'll quit breathing, the CO2 will go up. And part of the problem here is that you want to treat these people with oxygen because they're hypoxic, right? So if you give them oxygen, it's going to improve their hypoxia, but it'll also stop the respiratory drive, right? You know that. You've had that hammered home, I'm sure, more than once, probably 100 times now. So now you need to know whether or not you're giving them too much oxygen. If you're giving them too much oxygen, what's the only thing you can do? I mean, if a person has still got low O2 sats and you're giving them oxygen, what's that?
They're not getting enough through the lungs.
Well, you're sort of, I think you might be trying to go in the right direction there, but it's not quite what I'm looking for. If you've got a patient who's a COPDer and you're giving them oxygen because they're hypoxic, you don't want to have to intubate them, right? So you're giving them some oxygen, they're hypoxic, and their end tidal CO2 is going up. What does that tell you? It tells you that they're retaining CO2, right? And the only way you can solve their hypoxia problem now is by doing what? Ventilating. And there are two ways you can do that. What are they? What? You can bag them, you can intubate them, or you can use CPAP. Truthfully, BiPAP is way better. CPAP doesn't really ventilate people, but BiPAP does. And I don't know if you guys have BiPAP yet. It's something that I know they're working on for pre-hospital medicine. And I think it's really a great tool, but in a way it might be bad for you because it's already hard enough for you to get enough intubations. And if you're giving everybody BiPAP, then it's going to keep you from having to intubate people. In the setting of congestive heart failure, pulmonary edema, CPAP is great. You can solve that problem pretty easily. And the physiology of that is really interesting, but I don't have time to go into it. It's much more than it pushes the air out of the alveoli. I mean the water out of the alveoli. It's actually like giving, it's preload reduction, essentially. It's pseudo preload reduction. So it really cures CHFs, pulmonary edema, really quickly. But you can't reverse COPD and asthma and things like that as easily with CPAP. You can with BiPAP, but since you don't have that. Anyway, I'm getting off into a rabbit trail here. This is a good tool to help you tell whether or not you need to intubate one of these people who's continuing to be hypoxic in spite of the fact that you're giving them oxygen. And you can actually tell if you're causing oxygen toxicity, okay, by CO2 retention. So when you want to cut back the oxygen before the patient becomes intunded, but at the same time, if they're still hypoxic, you got to ventilate them. So here's one, end tidal CO2 and asthma COPD. So in the non-intubated patient, I think this is a really great way to use end tidal CO2. So you can use this to assess the severity of their extremis, okay? So if you have this sloping waveform, then you know you've got real bronchospasm. So if you have a patient who's wheezing and you think they might be a little bit anxious and they're being dramatic and all that sort of stuff, you put them on the machine and you see that they have this kind of a waveform, then you know you've got real bronchospasm. This isn't just anxiety, this is a person who's really got bronchospasm. And so this person received 2 doses of Combinab, and that's what you see. So did it work? Yeah. So you're thinking, okay, I'm probably not going to have to intubate this patient. If you gave 2 doses of Combinab, which generally I don't like to have people do, I like to do 1 dose of Combinab and then after that do albuterol alone, because ipratropium bromide can get a little bit toxic. It's essentially ipratropium bromide is atropine. I mean, think it's not atropine, but pharmacologically, in your mind, it's atropine. Everything atropine does, ipratropium bromide does, except it just does it in the pulmonary capillary bed. Okay, so you don't have to memorize both drugs. You can just memorize one or the other and essentially think them clearly. But so I usually like people to just do Combineb the first time around, because otherwise you're going to get all kinds of tachycardia and other problems that are going to make things worse. But this patient got better. I'll run through this and then we'll do some cases together, okay? I think this is just another example of the same thing. Somebody who had the initial waveform that you see above there, and then that's the improved waveform. You see their end-tidal CO2 initially was a little bit elevated, and subsequently the value has come down a little bit. The waveform has squared up, and so you can see that you're making some improvement. This is just another case. Initially, so I mentioned when we first started out, the progression of the changes in the waveform with asthma. This is also true of COPD exacerbations. But initially, the CO2 is going to drop because the patient's hyperventilating, right? And then as their condition worsens and they start to wear out, then they will basically they'll get fatigued, and so their respiratory rate will go down, and so they might actually go through what looks like normal before they actually drop into the abnormal phase. It's, you know, these COPDers in particular, these people are like pulmonary marathon runners. You know, their thoracic musculature is constantly working hard. And in fact, if you put one of those people on a ventilator for very long and allow those muscles to weaken some, it's almost impossible to get them off of the ventilator. You have to wean them off so that they'll redevelop that pulmonary muscle function, that thoracic muscle function. But once they wear out like that, the only thing you can do is intubate them or do BiPAP.
So if you're intubating a COPD patient, they don't necessarily need it right off the bat, how long do they stay intubated in the hospital on a ventilator? Do they try to get them off as soon as possible? And what are the criteria?
Yeah, they try to get them off as soon as possible because they don't want them to develop this kind of, what do you call it? No, it's kind of disconditioning or deconditioning. They don't want them to develop that, and it doesn't take very long for them to develop that. And so they try to get them off as soon as they can, but when they do start to take those people off of the ventilator, they have to do it very slowly. So they have to force them to sort of work. So they'll decrease the rate of the ventilator so that they'll have to do some work, and then they gradually wean them off over a few days. So they'll have to start picking up doing the work on their own. Thank goodness you don't have to bother with that. Thank goodness ER guys don't have to bother with that. That's something that happens in the ICUs. It's very tedious and it's very difficult, and you know, sometimes you just have to, it takes weeks to get people back going again. But the asthmatics are completely different. You know, you can reverse their disease and then they're fine. And the same thing is true of CHF, even more so. You can reverse that really quickly. So anyway, that's what you might see with asthma. I think this might be a little bit overstated, but supposedly you can tell the difference between cardiac asthma and bronchospasm. So, you know, you can have wheezing for any number of reasons. If you have, so this is your airway, okay? Your intrathoracic airway. So if you have asthma, what's happening is the muscles are in spasm, and that does what? It causes the airway to constrict, right? In the setting of COPD, particularly emphysema, well, if you're chronic bronchitic
So you're a blue bloater, right? There's pink puffers and blue bloaters, right? You guys know that stuff? So the blue bloaters are the chronic bronchitis. That's a variety of COPD. And the pink puffers are the emphysema people. They're the ones who, they're also COPDers. But you really have, it's important to understand that there are two different kinds of COPD. And the different physiologies are this. If you're a blue bloater, a chronic bronchitic, then what you have is a lot of mucus plugging in your airways. And of course that is going to narrow your airways, right? If you're a pink puffer or you have emphysema, what's the problem there?
Your alveoli are.
Why?
Because
What's the problem with your alveoli in your airway?
from smoking, they plug up, they pop, they collapse.
Why do they collapse?
Is there surfactant issue or just?
That's more a case with like membrane disease and stuff, and what's it called? Someone in the ICU. What? Yeah, ARDS. Right. Thank you. That's what I was trying to think of. My 68-year-old brain. But no, nobody's mentioned it yet. It's important for you to understand this. Emphysema. Why do people's airways collapse with emphysema? Yeah, who said that? Say it again, will you? Yeah, so you didn't go over my head that time.
Or mine.
Yeah, so you don't have the elastic recoil that you normally have in your airway. So when you don't have those springs pulling on the airway to keep it open, it collapses, right? So, and then why do people get wheezing with congestive heart failure?
The fluid in the lungs.
Yeah, it's partly that. It's partly that there's fluid in there, but it's mostly that you get a lot of edema in the lining of the lung, or in the lining of the airway, and consequently you get. So it's almost like what you see with chronic bronchitis, you know, with the mucus plugging, but it's not mucus, it's just swelling, and it's totally reversible because you treat somebody for CHF, pulmonary edema, and that immediately goes away. And that's part of the way you can tell that it's CHF. If you're not sure whether somebody has CHF or something else, you know, if they immediately respond to CPAP, then you know for sure that they had CHF. Okay, so supposedly this can help you distinguish. I think it is difficult to sort out some of these things. You know, everybody talks about airway sounds like it's just real obvious. Does anybody else here have difficulty with that like I do? Yeah. I had the advantage of being able to look at the chest x-ray before I dictated my note. So if I saw that there was an infiltrate in the left lower lobe, I'd say rouse in the left lower lobe. You know? Or if I saw there were bilateral infiltrates, then I'd say, yeah, bilateral. If I saw there was air trapping, I'd say, yeah, wheezing. You know? But the truth of the matter is, it's not that easy to just figure out what's going on by this nose. I think the pulmonary component of the physical examination is probably the least useful, to be honest with you. Chest x-ray is a great tool. When you can start doing that in the field, then you're going to really have an advantage. So I think I'm going to go away from this because I don't like this whole idea, so I'm going to skip it. Okay, so here's a lady who's looking like she's in big trouble. And you don't know. She's got COPD. She's been smoking for 100 years. And, well, not quite. She's not that old, but she's been smoking for a while. And she's saying, I'm really having a rough time breathing. So what are you going to do? You listen to her lungs. You don't hear a whole lot of air movement. You do hear some expiratory breathing. She's very anxious. She says, I think I'm going to have to be taken to the hospital or whatever.
Of course, you'll pay them to do that anyway. But, so what's the next step? Okay, do you want to do that before you put her on end-tidal CO2? I mean, I haven't put her on the end-tidal CO2 yet, right? So you want to put her on the end-tidal CO2 and find out, right? Or the waveform capnography. So you're going to see one of these patterns. If you see that top pattern, then you're not going to be so worried. If you see this pattern, then you're going to go ahead and give her the meds you just mentioned. And hopefully it'll normalize. She might just be doing this. Maybe she's just anxious and she's hyperventilating and she doesn't have any sharp fin formation at all. So it's really helpful for you to objectify what is otherwise a relatively subjective presentation. Now here's a really cool thing. If you have a head injury, so this is a trauma patient who's got, in this particular case, an epidural hematoma. And you want to intubate and ventilate this person because you know they need to have their CO2 dropped in order to improve their cerebral circulation, but you don't want to go so far that you shut down. What the balance that you have to get here is that you want to give enough hyperventilation to decrease the intracranial pressure by diminishing basically the blood going into the brain. But you don't want to get to the point where, because you essentially what you've got here is a box. And it's a fixed box. It doesn't get bigger or smaller. And there are two things in it, circulation and brain. Okay? So if you have a swollen brain, you got to make room for that brain. If you don't, it's going to herniate down through the uncus and cause you to have basically die. Okay? I mean, that's what we're trying to avoid until the neurosurgeons can get at the patient. So what you have this narrow window of time, but you want to buy some time so that they can get to the operating room and get cured, right? So you have to try to diminish the amount of blood going into the brain in order to make some room for that expanding brain. But at the same time, you don't want to diminish it so much that there's no circulation at all. Because when that happens, the brain tissue dies. So you have this kind of narrow space you have to try to work within. And the end-tidal CO2 can inform you about where you should be there. So hyperventilation decreases intracranial pressure by decreasing intracranial blood flow, right? But you just don't want to shut it off. So if you go too hard, you're going to get cerebral ischemia and you can end up with dead tissue. So you want to avoid a low end-tidal CO2. You don't want to go too low. So what's the target? Guys are so smart. Yeah, so you want to shoot for 30 to 35. I put down here 35, but 30 to 35. I've even read in some places 25. But I think if you shoot for 30 to 35, maybe 30 is optimal, you'll be okay. And then the optimal tidal volume is about 10 cc's per kilogram.
Doc?
Yeah.
We keep having best questions about like the epidural bleed, you can say with baseball. Is that something where
I've seen that happen before, by the way.
Yeah. If you
It's
start to
pretty
get
common.
offended with that and you start to notice that the CO2 levels are rising, is that something where you're going to want to take the airway before you kind of lose the stride once you start seeing that?
Yeah, for sure. Yeah, those patients got to be intubated and ventilated. Or, I mean, you should be quick to intubate and ventilate those patients. That's a group of patients that you want to get intubated quickly and get them ventilated. If you had BiPAP, I suppose that would be okay too for a kind of an interim stopgap measure. But it's I can remember a case of a kid here in town who was, I think his dad was actually the coach of the baseball team, high school baseball team. He was standing out in center field talking with one of his friends, and they were doing batting practice, and the ball got hit out there and hit him, boom, right here. And they brought him into the ER, and when he got to the ER, he was wide awake and alert, talking to me, just said he had a headache and all that stuff. And I sent him over for a CT scan, and while he was in the CT scanner, he arrested. And so I had to run over there and intubate him and all that stuff. So that kind of, I think that kind of taught me an important lesson about, you want to intubate those guys early. He did fine. He went to the operating room, got his brain drained and all that stuff. But it can happen really quickly. They can go from being wide awake and alert to out in no time. So just a word to the wise. Okay.
One other question, that optimal tidal volume, that's based on ideal body weight, correct?
Probably, yeah. But it doesn't matter because, your tidal volume is going to be the same whether you're fat or skinny or whatever. I mean, although that's a little bit untrue because you have this thing called Pickwickian syndrome. You've ever heard of that? So the really heavy people, really fat people, they get a lot of, because their gut is so big, it puts pressure on the diaphragm and diminishes their tidal volume. That's a kind of a specific situation. But in general, yeah, that's the way they figure it is on mean body weight. Ideal body weight, which no American has. I don't think. Not very many anyway. I certainly don't. Okay, so here's another one. Patients with DKA will hyperventilate because they're trying to blow off acid, right? So they will have a low end tidal CO2. Well, I shouldn't tell you that. You're going to have to tell me that. So the hyperventilation causes the end tidal CO2 to do what? Go down. So what's their O2 sat going to be? So how am I going to distinguish this from hyperventilation? What?
History. BGL.
Blood sugar, obviously, yeah. But I mean, the point is, if you're hyperventilating because of acidosis, it can look a lot like hyperventilation syndrome, right? So who are the people who have acidosis most often in your job? By far and away, the most are going to be the diabetics, right? People with DKA. But there's some other ones that are relatively common. What would those be that you can expect to run into? Yeah, certain kinds of substance abuse. Which drug overdose in particular is going to cause people to have acidosis? Drug overdoses. Well, not drug overdoses. Let's just say ODs.
Heroin?
No, not heroin. Well, heroin could because they're going to retain CO2. They're going to stop breathing. They're going to get acidotic, but they're not going to be hyperventilating. People who are hyperventilating because of acidosis. No, not as much. I mean, they can be hyperventilating a little bit, but that's not the group I'm looking for. Just think of those cases where you're going to have people who have severe acidosis. I think the most severe acidosis I ever saw in my life was a patient who overdosed on, I gave this person, aspirin is a good one. Aspirin is one of the more common overdoses that causes acidosis. That's a different story. I'm not going to throw that into this category, but to some extent you're right. But it's not a pure acidosis. But if they start to hypoventilate, it's going to be acidosis. Actually, yeah, I better not get into that because that could take us a while. I got a whole lecture on tricyclic overdoses. But now I can't find it because I can't find the thumb drive. Thank goodness you guys had this on. Okay, so the one I'm thinking of was somebody who drank coolant, ethylene glycol. It was when I was on the Navajo reservation. I did 3 years on the Navajo Indian reservation because they paid my way through medical school. By the way, it was a highlight of my medical career. I had a great time there. But I had a patient one time who was an alcoholic who couldn't get any alcohol and drank ethylene glycol antifreeze because that apparently will take care of withdrawals if you're having alcohol withdrawal. Yeah. But I gave that guy, I think, 20 amps of bicarb, and his pH was still less than 7. I'm really low. I mean, that's a severe acidosis, 7. And that was after 15 amps of bicarbonate. It's incredible.
What's the time frame giving it?
Oh, I gave him fast, like within 30 minutes probably. And I think that guy didn't survive, but I can't remember now. Anyway, so ethylene glycol, methanol, once in a while I get these crazy college kids who have these methanol parties where they just dump wood alcohol into a container and everybody drinks out of it, that kind of thing. But the most common ones are going to be aspirin, probably ethylene glycol, once in a while isopropyl alcohol. There's certain guys around Spokane who, when they can't find anything else, they'll drink isopropyl alcohol. I can tell you their names, and you would know them. There are a few of them. But anyway, the most common thing by far and away for you is going to be DKA or renal failure. People with renal failure can get acidotic too. You just have a lot of people on dialysis who haven't gone to dialysis for a few days because they just got tired of going or whatever, and then they can be very acidotic. So those would be the things that you would want to rule out if you think somebody is hyperventilating. Because it's the metabolic acidosis that's going to get you every time if somebody's hyperventilating and they've got a low O2 sat or a high O2 sat and a low end-tidal CO2, and you think, oh, it's just hyperventilation. So here's anxiety with hyperventilation syndrome. Don't ever do this bag thing. Okay. But so I think it's really cool to do this. If you're pretty sure you're dealing with hyperventilation syndrome. So if the person says to you, yeah, I have this problem with anxiety and hyperventilation syndrome, I do this all the time. You look at their O2 sat and it's down and their end-tidal CO2 is up, and you check their blood sugar and it's normal, and you know they don't have any history of kidney disease and they didn't take a drug overdose, then one of the things that I think is really neat to do is just put them on the end-tidal CO2. You show them the waveform, and you show them the number, and you say, you're hyperventilating. This is basically biofeedback. You're hyperventilating, and what I want you to do is slow down your breathing, and let's try to get your end-tidal CO2 number down to such and such. And that is a really neat way to coach people into not hyperventilating instead of putting a bag over their face. Because they see that number, and they can see if they breathe fast, the number goes down. If they breathe slower, the number goes up, and they can shoot for the target. I think it's kind of a neat, and they feel better too, because you know the pathophysiology of hyperventilation syndrome, why it gets to be a vicious cycle for people. So when you hyperventilate, what happens is you blow off CO2, and that causes what?
Vasoconstriction.
Well, it does do that, but when you so you're hyperventilating, you're blowing off CO2, and it's causing your body to become alkalotic, right? So your blood, your circulation, your body becomes alkalotic. So when you become alkalotic, how does that affect your calcium levels? So calcium is an ion that is pH dependent in terms of function. So if you hyperventilate, you become alkalotic, or you become alkalotic for any reason, your calcium will go into a non-biologically active form. It loses a charge and becomes a non-biological. You still have normal calcium levels. It's just that it becomes biologically inactive because it loses one of the positive charges. So what happens then? You start getting all the signs and symptoms of hypocalcemia, right? Which are involuntary muscle contractions, numbness and tingling around your mouth and fingertips and toes and all this stuff. So people start getting symptoms of a stroke or whatever. They start getting muscle contractions, and they start getting even more alarmed, and that exacerbates their anxiety, and it becomes a vicious cycle. So if you can interrupt that with this kind of biofeedback, if you will, then it makes people a lot better.
Does it reactivate the calcium or is that calcium?
Yeah, as they slow down their breathing and their pH comes back into the normal range, then the calcium shifts back into the biologically active form and they become asymptomatic. And they think you're marvelous. But you are. So pulmonary embolism, what would we expect to see there? Yeah, that's kind of the key, isn't it? So you have so you've got increased dead space. It's not getting ventilated, so you hyperventilate, right? So that goes what to your entitled CO2? Drops it, yeah. So you also get hypoxia. So the end-tidal CO2 is going to do what? We already said that it's going to go down. And what are you going to expect from the O2 sat? It's going to go down too, or at least it's going to be normal. So that's how you can differentiate, say, a pulmonary embolism or pneumonia or something that's causing decreased oxygenation of the blood. That's how you can differentiate those problems from things like DKA, hyperventilation syndrome, renal failure, etc. Are you guys going to remember this stuff?
Yeah.
Is it going to be helpful to you? I think it really does. I mean, it really objectifies all this stuff that heretofore has been pretty subjective. And that's part of what makes medicine a difficult science, is that there's too much subjectivity in there when you're dealing with human beings. So you're going to have a low or a normal O2 sat. You're not necessarily going to have a low O2 sat, but it's going to, yeah.
So this actually we had this patient just on Thursday morning, 20s kid, just had done meth, I don't know, 6 hours, no, seriously, had done meth about 6 hours ago. So super anxious, hyperventilating, trying to calm him down. So O2 sats are fine. His ATCO2 was a little bit low because he's hyperventilating, so trying to calm him down. Said he just didn't feel right. Okay, yeah, he did meth. We still took him to the hospital. Come to find out, we go back 6 hours later to the heart that he was actually intubated because he had PE. But we had no idea, no history, no. And then we're like, what else could we have done? I
Wonder why he had a PE.
I have no idea. I didn't get to speak to the doctor, the medic did, but yeah.
Wow, that's interesting.
I felt kind of like a little
That's a tough case.
super tough. He didn't present with anything other than he felt anxious, but the meth then really, he's tacking around at 140, so the meth really covered up.
Yeah, sure.
I mean, anything.
6 hours.
Yeah, he's still riding high. Yeah, so I don't know.
Yeah, no, I think any normal person would have attributed all that to the meth. But probably what happened was they observed the guy and he didn't get any better. And then they probably thought, hey, there must be something else going on.
I don't know.
A lot of times tincture of time is really a benefit. And you don't have that benefit.
How would they have found? Did they do like a chest X-ray or something maybe to find the PE?
Yeah, a chest X-ray is really not very helpful for a PE. So, in fact, most of the time a pulmonary embolism, they have a normal chest X-ray.
So would you have to do like an MRI at the chest?
No, but what? Just think about it for a second. What would you see on a chest X-ray if you had a pulmonary embolism? There are two things you can see. You don't need to know this because you don't do chest X-rays. But just I want you to think about what it does. What? Well, that's kind of close, actually. No, not on the chest X-ray. So you might see a wedge-shaped infarct, okay, because on the chest X-ray, which will look like kind of a wedge-shaped pneumonia, but usually peripheral. It doesn't happen very often. And then the other thing that you can see is an effusion because you've got dead pulmonary tissue. So this is a little further into the pulmonary embolism. You have dead pulmonary tissue that's weeping serosanguinous fluid into the chest cavity. And so you'll see a little bit of effusion. Very non-specific findings there, but that's much more common actually than the wedge-shaped infarct. The way you diagnose it is by doing a CTA. And that's really sensitive. It'll get it every time. Some people are doing it with the ultrasound now too, but I don't have that much experience with that, and I'm not all that convinced that it's good.
It's probably calling them some
Well, a D-dimer is real helpful. If, I personally, I don't even order a, and that could be what happened with him, is maybe somebody ordered a D-dimer and it was through the roof, and they said, geez, why has this guy got a high
Well, he's saying
D-dimer?
it's factor 5.
He what?
He had factor 5
Oh, well, that's the explanation.
for the PE.
Yeah, yeah. So there are these various blood syndromes that cause people to be hypercoagulable, and
Yeah.
factor 5 ligand deficiency is one of them. So, yeah, so that would have been the clue. That's why they ordered the CTA, I'm sure, is because of that history.
So when those people be on blood thinners or something?
Yeah. Yeah, they should be on blood thinners chronically, actually.
Meds.
Yeah, who knows?
But if he's taking methamphetamine, I think it's pretty unlikely he's being real compliant with his medication. I'm going to be done with going through this stuff here in a second, and then we'll go through some cases, okay? So here's kind of a little thing that I put together that I think will be helpful for you. So hyperventilation syndrome, so this is the same pretty girl with all of these diseases, okay? So with hyperventilation syndrome, you're going to see her O2 sat up and tidal CO2 down, right? With diabetic ketoacidosis, you're going to see the same end-tidal CO2 and O2 sat, but she's going to have a high blood sugar. And if it's renal failure, she's going to be on dialysis. If it's a drug overdose, then, you got to ask. If she has a pulmonary embolism, which is a possibility because after all, she's on birth control and she smokes cigarettes and all that kind of stuff, which by the way is a lethal combination for pulmonary embolism. I've seen a lot of young women with strokes who smoke and take birth control pills, just so you'll know. That's kind of suppressed information. We don't like that to get out, because then kind of obstructs the agenda. But the truth of the matter is it is a risk. So if you're going to take birth control pills, don't smoke. So anyway, their O2 sat for pulmonary embolism will be either low or normal, and the end-tidal CO2 will be low, predictably. And then how do you distinguish that from pneumonia? You're going to see the same kind of thing as with a pulmonary embolism, except that generally they're going to have a fever. And the other thing is, if you listen to their lungs, you're going to hear unilateral rows, right? Even though I just told you that a lot of times I can't tell the difference. I expect you to be better at it than me. But
What if your thermometers don't work?
you can ask the person if you had a fever, if you had chills. But that is a big problem with PMS. Yeah. But if you're not a mother, you don't know that. The average mother can tell if somebody has a fever way better than anybody else. But anyway, you do have a problem with your thermometers, that's for sure. Is it any better than it was when I was doing this?
No.
No? So then it can also be used as a perfusion warning sign. So this is part of their end-tidal CO2. Early warning sign is shock, sudden drop in cardiac output will drop the end-tidal CO2 regardless of the change in breathing. And then, so for trauma patients, cardiac patients, anybody who's at risk for shock, that's a good thing. Here's capnography in full arrest. So you got somebody that you're doing CPR on. So this first half of this line is bad CPR, and it's good CPR. So at some point, somebody adjusted either their rate or the depth of compression or whatever it was. I don't know here, but the end-tidal CO2 goal is about 20 when you're doing CPR, and that's actually more helpful than the metronome. But you want to go 100 or so. You want to go deep. You want to go hard. You don't want to stop.
And that's the waveform of just CPR, no bagging.
That's right. Yeah. Yeah, but you can tell whether you're doing good CPR with the waveform. It's kind of neat.
So that's
This is actually the end tidal CO2, not the waveform. This is just the trend line of the end tidal CO2. What were you going to say?
So that would just happen oxygenation, or is that going to be altered by how fast you bag?
It's going to be affected by how fast you bag, and how fast you do chest compressions, how deep you do chest compressions. Because those things are all.
If we're getting good, like perfusing pulses, and we're at 35 to 45, it's just hyperventilating, or it's just
Well, if you're at 35 to 45 doing CPR, yeah, that's pretty damn good. I mean, that's way better than I would expect. If you're actually doing if you're at 35, you better stop CPR because they've got circulation, right? I mean, if your waveform all of a sudden, if your end tidal CO2 all of a sudden jumps up to 35 or 40, then something has happened, and it ain't your CPR that's giving you that kind of a waveform. So you know you've got restoration of normal circulation at that point. Question?
I was just saying, so we ran quite a while back. We were in the mid-20s, yeah. 2 days ago, well, so he was in mid-25. They were talking about chest compressions. Meg said data we needed to slow down. Or no. Would you hyperventilate or hypoventilate?
Well, as you know, ventilation is kind of overvalued in CPR when it comes to, a guy who falls off his chair with a cardiac arrest. If it's a ventilatory arrest that caused a cardiopulmonary arrest, then that's a whole different story, right? You can go into that, right? If it's drowning or if it's a kid or, one of those things, then you want to be thinking about ventilation. But normally, if I fall off of this chair right now and go to cardiopulmonary arrest, my problem is not ventilation. I'm blowing smoke right now, right? So I mean, I'm breathing just fine. I don't have a problem with oxygenation. I got a problem with circulation. And so, at least for the first 5 minutes or so, the most important thing is to circulate the blood. But I think you want to shoot for an end tidal CO2 of 20. You can do that both by ventilation and by doing your chest compressions properly. So when you get a return of spontaneous circulation, your waveform is going to normalize. So there's an example of that. So you see, the rules are that you do chest compressions until you get to a certain point, and then you stop and check, right? But you got to do 2 minutes of CPR before you. So this is what happened. So they stopped, and boom, there they have normal normal waveforms and normal levels. I think this is the last thing I'm going to mention before we do some cases together. So when you get a return of spontaneous circulation, your waveform or your end tidal CO2 value is going to jump back up into the normal range. And then some good studies have shown that if you have consistently low end tidal CO2 during circulation of less than 10, then the likelihood of you getting recovered is pretty minimal. That was a good article published in the New England Journal of Medicine, which is kind of almost like the gospel for medicine. Usually the stuff doesn't get published in that journal unless it's pretty good. So if you get an end tidal CO2 of less than 10, and you're doing good chest compressions and you've worked at it for a little while, it's probably okay for you to call the code in the field because that person's probably not going to survive. Now, I don't know if your protocols allow you to do that now or not, but I think it's a reasonable thing to include in the protocols. So if you're doing a resuscitation in the end tidal, or you have resuscitated a patient and the end tidal CO2 drops off significantly, then you want to immediately check their pulses. And if they don't have it, you want to restart CPR. So don't just assume that the tube has been displaced. Might just be that they've gone back in the cardiopulmonary arrest, right? So there are two things that could cause you to lose your waveform. Either your tube got displaced or plugged, or you lost your circulation. So here's an example of somebody who kept going in and out of cardiopulmonary arrest. kept getting return of spontaneous circulation and then going out. So this is just review, basically, the stuff we've already talked about. Kind of summarization. This is just the magic trick end-tidal CO2 predictor of resuscitation. So that's that journal article I mentioned to you earlier. So if you're 20 minutes into it and you've got somebody with an O2 or with an end-tidal CO2 of no better than 10 millimeters of mercury, then probably they're not going to make it. That was in patients with PEA, by the way. So most of them don't do very well anyway. If they got V-fib, that's a reversible rhythm, and I wouldn't quit on that ever. You know, if they're going in and out of V-fib, then you just keep working them. But if they go into asystole and have an O2, or they have an end-tidal CO2 of less than 10, then you might as well forget it. It's a done deal. You lost. And the higher the value, the more likely you're going to be successful. Oh, this is kind of an interesting thing, but it's probably not all that relevant to you. If you have a cardiopulmonary arrest, you can actually sort of figure out whether it was cardiac or pulmonary, but it's also through the retrospectoscope. So you have to have resuscitated them, and then you'll have some clues as to what the etiology was. So it doesn't really help you in terms of determining how you want to treat them. But if you do get them back, the interesting thing here is that here's a case where you had all these people who died of either respiratory etiology or primary cardiac. And predictably, what you see is a high end-tidal CO2 initially because they stopped breathing. So here is the initial reading for the people who had the asphyxia. Okay, it was really high, whereas it wasn't high for the people who had initial cardiac etiology. And then after 1 minute, they're sort of getting into the same range. Okay, and then you get down to the final recording and they're basically the same. And that's just because the people who had asphyxia had backed up CO2 once they started breathing. But this is really not very helpful for you. It's kind of a, oh, that's interesting. Right? Oh, here's one I like. Right. So you can tell when somebody's about ready to pull their tube out before they do it. You know, one of the worst things in the world is you really work hard to get somebody intubated, and then as they start to wake up, they pull the tube out. And so you got to decide whether you should sedate them again or just let them pull the tube out, right? But this is called, so that's called bucking the tube. You know, you've heard that term, right? It wasn't easy for me to make this slide. You could see how I had to kind of cut the cowboy out of there. Anyway, so with bucking the tube, you get this thing called the curare cleft. So you're looking at your waveform, and you see this little cleft, and that means the person's about ready to start breathing again. Or at least the succinylcholine is wearing off, and you either need to give them a depolarizing agent to keep them paralyzed until you get into the ER, or you need to let them pull their tube out, one or the other. Okay, so these are the cases. Why don't we take a break, and then we'll try to blow through these cases fairly quickly and get them done before lunchtime, which might not be possible.
Pull that one out.
We actually had that.
What's it called again?
Cell activation syndrome.
That should have been one of those types where I got from the back of the head, right?
We had it on
believe you.
I believe you. No, I totally believe you.
This chick out in
Well,
the Turkey
that
Head
always
has
gets
that.
Should I have practiced that?
I was waiting to hear that. Like,
I was there recently.
Do you have one crossover? Are you in there all that?
yeah.
There's like a 5-year gap between the two.
Yeah.
Kind of like.
Yeah.
Yeah. Do they keep water? Yeah, where the
X's in the middle.
yeah. Yeah, there you go. We always make fun of each other. The walls.
Yeah, I'm that.
Yeah, you're in the walnut bracket too.
Yeah.
Well, it's funny, like, Scott is, out white.
Yeah.
And she's through the door, and so she falls in the.
Is he done?
I just, no,
I gotta do this real quick.
I just paused that.
You were good to go.
Okay. So we're gonna go through some cases here real quick, okay? Just so you can apply what we've just learned to cases. So you and your partner work in a cardiac arrest, you're successful with the resuscitation, patient's still unable or still unstable, and you made the decision to load and go because very short transport time to the ER. I know you're supposed to sit around for 10 minutes until everything is done and all that sort of thing, but if it turns out to be 8 minutes, I'm not going to have a lot hard about that. And I doubt if your medical directors would either, as long as you get everything done. But the reason for that is because people can refibrillate if there was a VFib cardiac arrest. And usually they'll do it within the first 10 minutes. And if they don't do it within the first 10 minutes, they're not likely to do it. And it's hard to do CPR in the back of a moving ambulance and all. So that's the rationale for all that stuff. But anyway, you've decided that you're going to load and go, and so the patient is intubated. Your end-tidal CO2 shows a nice waveform you see there. So perfect end-tidal CO2 reading, perfect looking waveform. Patient's still not breathing, so you're ventilating. And you got a blood pressure of 100/70, which is adequate, not the greatest, but it's good enough. Pulse is 88. You're assisting your respirations. O2 sat 100%. End-tidal CO2 couldn't be better, right? So after loading the patient in the ambulance, you resume ventilation, and the capnography alarm sounds, and that's what you see. So what's happened? What happened now? Okay, so I've heard two things. Either the tube got pulled out when the patient was moved, or the patient has arrested again. And it should be, if it was a multiple choice question, it would be A, B, or A and B, or none of the above. It's C, both. So the patient either went into cardiopulmonary arrest again, or extubated when you moved them. And that's very common. That's why they ask you to put a cervical collar on people after you've intubated them, because that rotational component is just enough to dislodge the tube. So how do you know? Which was? Yeah, check a pulse. So you check a pulse, you don't have a pulse, then you start CPR again. If you do have a pulse, then what?
For lung sounds and epigastrics.
Yeah, so tube's either not properly located or you have a total airway obstruction. You better check the machinery to be sure you don't have something disconnected. And then it could be that the patient stopped. So you guys know the, so you want to assess the perfusion status, which you've already told me to do. So if the patient does have a pulse, you want to determine the patency of the airway, or whether it needs to be repositioned. And when in doubt, take it out, right, and replace it.
So, oh yeah, so this gives you some idea of my political inclinations. I used to have Alfred E. Newman up there, but I consider them to be one and the same. So this guy has the biggest carbon footprint in captivity, and yet he has nerve enough to go around and tell all the rest of us peons that we're supposed to diminish our carbon footprint. Anyway, so if you have an O2 sat drop and the patient is difficult to bag and tidal CO2 drops, what are the possibilities? The dope in the ground.
Lodgement, obstruction, pneumothorax, and equipment.
Exactly. So those are all the things to consider. The tubes come out or is obstructed, which is not unusual at all, particularly in a trauma patient. But you know, if you had a difficult intubation, you might have gotten a big blood clot stuck in the tube. Could be a pneumothorax. I mean, it's very common for you to give someone a pneumothorax doing chest compressions, right? Especially if you do them properly, hard and fast. It's a good possibility you're going to pop a lung. So always think about the possibility of pneumothorax. Could be equipment failure. Here's a 16-year-old male with a long-standing history of asthma. School nurse calls 911 because he's suddenly short of breath in gym class. By the way, beware of school nurses. I used to get predictably at least one complaint a year from a school nurse about the paramedics. It's almost like they feel like they're in competition with paramedics or something. I don't know. It's a weird phenomenon, but I'm just telling you, be on your best behavior when you get called to a school by a school nurse, because they're really critical of paramedics for some reason. I don't know why, but what? Oh, and it's usually somebody who has, quote, an allergy, and you go there and you say, you know, I don't see a rash, and the kid doesn't have any gastrointestinal symptoms, and I really don't think this is an allergic reaction. I think the kid's just hyperventilating, you know, and then you go away, and then an hour later the kid does have an anaphylactic reaction, and then you look bad, and they always feel obligated to complain to the medical director about the paramedic care. So just beware. They're on the side of being overly solicitous, overly kind, and overly careful about taking the patient to the ER or whatever you're going to do. Okay. Anyway, so the school nurse called about this kid because he's becoming suddenly short of his breath. Why did I use a picture of an African American kid? Well, because they have a much higher incidence of asthma than non-African American kids. I did my internship at a place called Grady Memorial Hospital in Atlanta, Georgia, right in the middle of that giant inner city kind of ghetto area in Atlanta, 2,000-bed inner city hospital. We had a whole room about the size of this one dedicated to asthma. So in the ER, instead of admitting these patients to the hospital, we would just put them in that asthma room, and everybody was in there getting treated for asthma, you know, per protocol. I'm not sure that was a very effective thing to do because you got a bunch of people in there all trying to fight asthma at the same time, and I must have been, if you could measure the anxiety titer in the room, it must have been remarkable. But anyway, but that, you know, probably 95% of our patients were African American. It was very common for people to have asthma exacerbation. That's just a side note. But anyway, so on evaluation, he's clearly in respiratory distress, speaking only with one-word sentences. Blood pressure is high because why is that? Yeah, because he's got stress hormones floating all over the place. But, you know, epinephrine is kind of the common endpoint of all stress in human beings, adrenaline, essentially. So in my book, the most reliable measure of whether or not you've got legitimate dysfunction is what? Pulse. Yeah. I used to tell my nurses, I don't want anybody discharged from this ER with a pulse over 100 unless I know why it's over 100. Because that is the best way to know that you got problems on your hands. So heart rate of 130, respiratory rate of 45, which is quite high. And in spite of that, in spite of his high respiratory rate, his O2 sat is 89%. So he's in trouble, right? Diaphoretic, tripod position, accessory muscles, nasal flaring, all that stuff. Bilateral expiratory wheezes, you know that because you looked at the chest x-ray and saw air traffic. I'm just kidding. You can hear wheezing pretty well. Most people can figure that one out. It's just the rouse and the wrong guy and all that other stuff, you know, we'll talk about. But anyway, bilateral expiratory wheezing, end-tidal CO2 is applied. What do you expect to see? Sure. So you do. So you immediately administer oxygen. The patient on a monitor, start an IV, give them nebulized albuterol. You could start off with Atrovent or Condivent, like I said earlier. But I usually only do that once. And in this kid, you know, he's tacking along at 140, so you don't want to give him too much ipratropium bromide. Is there a question on that?
I was going to ask, so when ipratropium bromide is dry out, but he doesn't really have the issue with fluid in the lungs? Or what?
Well, ipratropium bromide isn't just to dry him out, it actually opens his airways.
Oh, okay.
Yeah, atrophine's a bronchodilator too. Yeah. So ipratropium bromide is actually a bronchodilator, like albuterol.
Oh, okay. So you're just doubling that.
Yeah, it's just that albuterol, I personally believe you can give albuterol with impunity to anyone. Now, there's some people who contest that. You know, there are other doctors, medical directors I know will say, oh no, you can't do that. I think you can give albuterol to anybody, anytime, as much as you want. And you're probably going to be okay with it. That even includes people with congestive heart failure. Because it's very difficult to tell whether somebody's got congestive heart failure or COPD exacerbation a lot of times. Because a lot of people have what's called, shoot, now I can't remember the name. It basically, they have emphysema-induced heart failure. What do you call that? The name for it. What? No, it is a comorbidity. It's a common comorbidity. That's why there's a name for it, but I can't remember what it is. I'll think of it. But anyway, because of the fact that they've got chronic pulmonary dysfunction and chronic hypercapnia and hypoxia, they develop cardiac dysfunction. And so you can have people who have a combination of congestive heart failure and COPD, and it's really difficult to sort it all out. So I just say, if when in doubt, you can give them albuterol. If you're pretty sure that you're dealing with bronchospasm or COPD exacerbation, pure COPD exacerbation, then you can start off with Condivent. You probably get away with doing that one time regardless. But if you're going to do repeated treatments, I think it's a good idea to just go with albuterol. Have you ever heard that before? Or is that just my quirk?
Just follow it up with albuterol?
Yeah.
I think that's protocol.
Is it?
Yeah,
So,
yeah. One dual negative.
oh, okay. Well, that must have been because I was sitting at the table. Yeah, somebody actually paid attention. You put them on end-tidal CO2, and there's what you see as your waveform. So the patient is hyperventilating. He's got a low end-tidal CO2 23, and he's got that classic wave, sharp fin. So is this kid sick? Yeah, he is. Are you going to have to intubate him? Good possibility you will, though, huh? Could you get away with giving him CPAP? Yeah. CPAP works for asthma, but not very well. It's not like, if you put CPAP on somebody who has congestive heart failure and pulmonary edema, they are going to get so much better that people are going to have a hard time believing that they were dying 20 minutes ago. I've admitted more than one patient to the intensive care unit in pulmonary edema, put them on CPAP or BiPAP, because I have BiPAP in the hospital. And then the cardiologist calls me 20 minutes later and says, "Why'd you admit this guy to the ICU?" And I say, "Well, because he was dying, you know." But that's how quickly they get better. And then they make you look like you're overreacting, but you're not, because they just get better. Now, so do you guys want to understand how CPAP works in the various kinds of things that you use it for? Or is that irrelevant to you? All right, so let me see if I can think of how's a good way to show this.
Is there any chance you can do it on Blackboard?
Yeah, sure, yeah. That makes good sense.
Suppose you want it on this board.
It shows your seat. So let's say this is your thorax, okay? So this is your thorax can expand or shrink, and that's how ventilation takes place, right? So I think of how's the best way to demonstrate that. Okay, so let's say here are your lungs. Here is your left heart. Here is your right heart. Remember when you were in junior high, you had those things that your girlfriend got one half and you got the other half. So it's like, that's her. And so the blood flows through like this, right? And the only reason it goes like that is because there are a series of valves in there that only allow the blood to flow in one direction, right? So that's why CPR works, by the way. You create pressure within the thorax when you press the chest down, and it pushes the blood out of the thorax, right? Because you created pressure within the thorax, but it can only go in one direction because you got a bunch of valves in there. And then when you take your hand off, this is why it's important to come all the way off. Then you create negative pressure within the thorax, it sucks blood in there, and then you push it out again when you do chest compressions, right? That wasn't the point of drawing this, but it just seemed like a good idea to point it out. And while I've got this here, never mind, I won't go there. So let's say you have a patient who has pulmonary edema. Their lungs are filling up with blood because the circulation is backed up. So this would be, you'd have to have left heart failure to get pulmonary edema, right? With right heart failure, you don't get pulmonary edema, right? That's how you distinguish the difference between right and left heart failure. So this is a side note, but if you have a right ventricular infarct, you guys heard about that yet? Never mind, we're not going to go there. But let's just say if you got right-sided heart failure, you're going to have distended neck veins, which is a measure of high preload, right? You can have low blood pressure, which is the measure of low afterload, right? But you're going to have dry lungs because the fluid's backing up this way and the lungs are spared if you have right heart failure, okay? If you have left heart failure, you're going to have these same things, distended neck vein, low blood pressure, but you're going to have what? Wet lungs, okay? So the way you
Will you still have the distended neck veins?
Yeah. Either way, if you got any kind of heart failure, you're going to have distended neck veins. Doesn't matter whether it's right-sided or left-sided or both. And if it's significant heart failure, you're going to have low blood pressure as well. But here's the point that I drew this for, and I realized, gosh, this is a great way to show you a lot of different things. But what happens with pulmonary edema is your lungs get all full of fluid, right? And so you put somebody on CPAP and they get better. Is it because the fluid is getting pushed out of the lungs? That's the main reason it works. It doesn't really make that much difference in terms of getting fluid out of the alveolus. Now, there is a situation where it does work for getting the fluid out of the alveolus. Which one is that? What? No. Drowning. So if you have somebody who's drowned and you put them on CPAP, which is a very reasonable thing to do, you might make them better real quickly because you're just pushing the fluid out of the alveolus into circulation. Okay, but in the setting of pulmonary edema, what's happening is if you increase the intrathoracic pressure throughout the whole series, inspiration and expiration, and you do that by putting them on CPAP, right? You put them on CPAP, what you're doing is you're increasing intrathoracic pressure, right? So what you're doing is you're increasing the intrathoracic pressure, which is creating a gradient from extrathoracic to intrathoracic, okay? So it doesn't matter whether you increase the intrathoracic pressure or you decrease the preload. Essentially what you're doing is you're decreasing return of blood into this whole system. So you can't say it's preload reduction. What I call it is pseudo preload reduction. So what you're doing is you're creating a gradient which is diminishing the amount of blood that's returning to the heart. And what does that do? What's the pathology of congestive heart failure? What is it that causes a heart to quit contracting? You guys know about the Starling curve yet? Have you studied that? It's a complicated way of telling you that what's happened is that the heart has dilated up enough that the actin and myosin components of the cardiac muscle are not overlapping the way they're supposed to. So they're not getting traction on one another because they're stretched. And when the heart starts to shrink down, all of a sudden those things get traction and the heart starts to contract again. So you can reduce the size of the heart by either decreasing the preload or increasing the intrathoracic pressure or both. So if you give somebody CPAP and nitro at the same time for congestive heart failure, their heart's going to shrink down and all of a sudden it's going to start contracting and it's going to start moving blood. And that's why people get better with CPAP. It's pseudo preload reduction. It has nothing to do really with pushing fluid out. Now, when you give it to somebody who has a COPD exacerbation like a chronic bronchitic patient, well, it's better to talk about emphysema. It works better with emphysema because they've lost their elastic recoil. And so when you've lost your elastic recoil, what happens is every time you breathe your air out, your alveolus collapses. You know how hard it is to blow up a balloon, right? When you first start blowing up the balloon, it requires a lot of work. And then once it gets to a certain point, it just expands right out, right? It's the same thing with an alveolus. The smaller the thing collapses, the harder it is to re-expand it. So what you're doing with CPAP is you're keeping that alveolus from completely collapsing. So you're just diminishing the work of breathing. And it's essentially the same with asthma and pneumonia, but it's much less of an effect. So if you think in terms of most effective for congestive heart failure, pulmonary edema, pretty effective for COPD, particularly chronic emphysema exacerbations. And then effective, but not impressively so for asthma, pneumonia, pulmonary embolism, those sorts of things, okay? All right, I got off onto a tangent again, I'm sorry. But it's good stuff to know, don't you think? All right, so which case are we on now? This is the, does this guy need urgent CPAP? Wait a minute.
It's still a kid who hasn't been.
Yeah. He changed colors. Yeah. I wasn't thinking very well. Yeah, this is Michael, right? So needs urgent CPAP. I guess I just picked that out because of the picture of somebody on CPAP. There it is. But it's changed sexes now. Which is really,
Let's just move on.
It's got to be a fairly common cultural phenomenon. So it's conceivable you might encounter that. So does this patient need urgent intubation or not? You're going to ask yourself that question, right? So how do you figure that out? after 5 minutes of treatment with Duomab, Condiment, whichever one you use, end-tidal CO2 looks like this. So do you think the patient needs to be intubated? No, probably not. They're responding pretty well to the medication. That's not to say that you're not going to be vigilant and careful and all that stuff, but you can sort of relax a little bit and go about doing other things. You're probably not going to have to intubate. You're probably not even going to have to use CPAP. Okay, this is number 3. This is an 80-year-old female who has